3 lumpy shoulders. What are the causes? Answer at the end. Welcome to this week's webinar. We'll be discussing hip extension hypermobility caused by subluxation or jamming of the hip joint, or it might be caused by labral impingement. There's no good way of knowing in your clinic, but we will model it as a biomechanical hypermobility, as this works well for visualizing, diagnosing and treating whatever it is that is going on. Don't be put off by this. Pretty much everything we do in manual therapy is based on models rather than hard science. And the use of models, more stringent admittedly, is used in the hard sciences, physics, chemistry and biology. In my experience, hip hypermobility into extension is a very common cause of both lumbosacral and sacroiliac joint dysfunctions, and almost invariably easy enough to treat. So here goes. The following is heavily based on a best friend's work. Galmalai earned a DSc from Andrews University for research into the subject of biomechanical dysfunction of the hip. In fact, I wouldn't know anything at all about the subject if she hadn't taught me. Gal is among the smartest, most hard-working and determined people I know, and it's a pleasure to be her friend. I'm going to give my slant on an aspect of her work as I see it, and not as an improvement or even a modification of her work. The dysfunction I'm going to talk about may be and probably is a milder version of the one she usually describes, but I'm going to change the model to fit my worldview, and I hope you will forgive me for doing so. But I am renaming the dysfunction, and I hope to distinguish it from hers and give the opportunity for her to divorce herself from it completely. Perhaps I can convince her to do a webinar on her own terms on this subject. The painful dysfunction, which requires an etiological search, can be any or all of the above conditions. They will all have ipsilateral pain, assuming that they are painful, and given that they are seeing you is a reasonable assumption. On biomechanical assessment, they will be found to be sublux or jammed into extension, resulting in a flexion hypermobility, or if you prefer for the SIJ, an anteriorly rotated innominate. A prolonged stress has forced the lumbosacral and sacroiliac joint into hyperextension, then destabilized it so that one or both are jammed into extension and are unable to flex. There are a lot of things that can cause biomechanical extension hypermobility of the ipsilateral and sacroiliac joints, but none is, at least in my opinion, as common as a hypomobile hip. The flexion hypermobility will stress the lumbosacral junction and the SI joint in two ways. First, if the hip cannot extend, then extension must occur elsewhere. And the two closest joints are the SIJ and the lumbosacral junction on that side. The spine ipsilaterally hyperlordoses, forcing these two further into extension. Over time, with these two joints hyperextending, they finally destabilize by being pushed too far into extension and then subluxing into it. This is particularly true if one or both of the following also obtain. First, the individual is into repetitive stressful activities such as running, dancing, etc. And two, another hypermobility in the same leg cannot help disperse the stress. For example, the sacroiliac joint is unable to extend, or the ankle cannot fully dorsiflex and so help shorten the leg. To a lesser extent, if the other leg cannot lengthen sufficiently to compensate for the long leg caused by the hip extension hypomobility, it cannot help relieve the stress. It is likely that a mild osteoarthritis of the hip starts the process. In itself, it is painless, but if reflex inhibition occurs as a result of inadequate proprioception, dynamic stability of the joint is impaired, the neutral zone increases, and end zone instability occurs. Pathomechanical flexion hypomobility results, or perhaps the labrum degenerates and becomes included in the joint. Regardless, hypomobility of hip extension will result in a dynamic long leg that cannot be seen in standing or laying, but only when full range extension is required, when it's needed in running and walking. If it is uncompensated, it will show as a vertical limp off of that leg, but if overcompensated, the gait may be normal, or it may actually be short. But the presence of a collapsed foot, extension hypomobilities, valgus of the knee, and other breakdowns, plus the hip extension hypomobility, will argue that there should be a short leg, but none is apparent in weight bearing. Just to review the process diagrammatically, this is as I see it with some minor variations which are less common and will be ignored. The hip appears to be one of those joints that for some reason degenerates early for reasons other than trauma. Note the number of hip replacements compared with other joints. The thinning cartilage results in mild articular instability. This leads to reflex inhibition due to inadequate proprioception. This inhibition weakens the stabilizing muscles of the hip, allowing an increase in neutral zone. The process then continues with negative feedback until the end zone is breached and a subluxation or labral tear occurs and blocks medial rotation and its extension. This then stresses the lumbosacral and sacroiliac joints, causing instability, and then, at least in some people, subluxation into extension with flexion hypomobility. Aggravating factors are locomotion. The more forceful, the more aggravating. Also not helping are other dysfunctions limiting dispersion of forces and the physiological effects of decreased proprioception, again reflex inhibition, and pain with facilitation. It means that if the hip cannot provide its fair share of extension, the lumbar spine and SIJ have to take an unsustainable force and eventually break down. The hip, which is usually painless at this stage, is subluxed into lateral rotation, meaning that there is no range of motion into medial rotation, which in turn is the conjunct rotation of extension. So if medial rotation is limited, then so must be extension. Whether this is a subluxation exclusion or an inclusion of the labrum, I have no way of saying, nor for clinical pragmatics does it really matter. It might be one thing in one patient and the other thing in another, or it could be something quite different altogether. For the purposes of visualizing the condition and designing an intervention, it does not really matter. A model does not have to be true, it simply has to explain the observations and develop an intervention, and this model of biomechanical dysfunction does that. It's hard to state that it is a scientific model, as most of these are mathematical, but the principles and methods are the same. The diagnostic criteria, or if you prefer an essential illness script for the hip, is as above. Generally the hip is painless, and it is the low back pain that brings the patient in for treatment. However, if there is pain from the hip, it is usually in the groin, so do not assume it is referred from the low back. Almost always all five are present, but sometimes the arthrokinematic is positive for a hard capsular infill if the subluxation occurs within a tight capsule due to arthrosis. It is unusual, but sometimes compression must be added to the inner flexion quadrant scale test to elicit pain, but it generally feels blocked, often very early in the range, and this is painful. Extension can be limited by 50% compared with the other hip, but it must be tested correctly. The stabilizing hand must be on the ischium to prevent the pelvis rotating anteriorly and not on the ilium, which encourages this movement. If not done properly, the motion loss can be lost in the general tilting of the pelvis and the lordosis of the spine. I would suggest testing medial rotation in prone with the knees flexed to 90 degrees and rotating both legs outwards for immediate comparison. This stabilizes the pelvis appropriately and shows even small amounts of loss and allows you to simultaneously compare end fields. This is a very common cause of a very common condition. You can, of course, simply manipulate or mobilize the lumbar spine and eliminate the pain and dysfunction, and the patient may well be good for 3 months or longer. If this is your choice, I wouldn't bother carrying out stabilization or rehabilitation therapy, as the mechanical forces generated by the hip has broken things when they were healthy, let alone after they have been band-aided. But although not proven, the option for the patient to have a search for etiology and movement rehab carried out should be on everybody's to-do list, just in case it does help. That is, the patient should be offered the opportunity of agreeing to etiology treatment and rehabilitation. However, it is worth noting 2 things. First, when treating an asymptomatic etiology, there is a risk of it becoming painful. This is much worse than making something worse, and there is a good chance that neither the patient nor the physician will trust you again. So make sure you explain this risk to the patient clearly and have him or her agree just as clearly so you can share the responsibility of how much time and effort is involved before you invest in starting such a program. First, start with where the mass is. In A and B, it is over the AC joint line, and once again, palpation is your friend. Is the mass fluctuant or not? If not, it is unlikely to be fluid, leaving fibrous cysts, lipoma, or in this case, bone. Photograph A is a separated AC joint, and of course trauma with immediate severe pain is a key finding. B is a joint cyst, and if you cannot be sure of the difference between bone and fibre, then the history will definitely help. A subcutaneous bursa lies over the AC joint, and this can swell and look similar to A and B, although perhaps a little less well defined, and it will be fluctuant. C is a subdeltoid bursa, and it has to be very large to be visible, as it has to appear through the deltoid mass. This is of an older lady with less muscle, so it helps. Always remember that a large bursitis can be caused by rheumatic disease and infections, so these should be excluded, but if in any doubt, refer. Dysaphasia is defined as a sensation that replaces the sensation normal to touch. It is often painful, and this pain includes lancinating pain, coursalgia, paresthesia, burning, etc. But it might simply be different to what should be felt and not necessarily be discomforting. It is caused by neuropathies, spinal cord injuries, diabetes, MS, alcohol withdrawal, thalamic stroke, and fibromyalgia. Allodynia is pain perceived as a response to non-painful stimulus. Causes again include neuropathy, CRPS, postherpetic neuralgia, fibromyalgia, and migraine. Paresthesia is a denervation sensation, is how you understand it. However, it is arguable whether tingling as an abnormal response to touch, which is dysaphasia, is the same as denervation paresthesia. Coursalgia is a form of neuropathic pain, usually caused by peripheral neuropathy, that is of burning or itching quality. And lancinating pain is felt as an electric shock and is another form of neuropathic pain, usually due to damage to the spinal nerve or